All right. So, evening, everybody. I'm David Chu. I'm one of the neurosurgeons at OSU, and I'm going to be giving a talk about a topic near and dear to my heart, which is how we approach the thoracolumbar junction. So, a lot of this was based off of work that I had done in residency, and the information that I'm giving to you all today is something that I use in common everyday practice. And I chose this topic because when we talk about the thoracolumbar junction, especially with lateral approaches, this is kind of a nebulous area. The anatomy is confusing. We're not frequently there. But my hope is that I can simplify that process for everybody. Okay. Um, for most of my talks, I generally give like a summary slide at the very beginning. This is like the cliff notes of the entire talk. So if you want to just screenshot this and then just sign off, you'll probably get the gist of most of what I'm talking about here. So what I'm going to go over is that, in my view, there's really three ways of approaching the thoracolumbar junction, which is what I define from T10 to L2. We can either go and stay within the retroperitoneum and just kind of bend a retractor, move ribs up. We can stay at the top portion of the retroperitoneum and actually go behind the diaphragm and detach the diaphragm and actually move it upwards. And then the last way is we actually are in the actual thoracic cavity through either a retropleural or transpleural approach. And which of these approaches you use is highly individualized, not only depending on what type of surgery you're doing, but more specifically the patient's anatomy. And a coronal CT, or if you have a coronal MRI scal, can really help differentiate what you're going to use. And in my view, the reason why I care about this so much is using a lateral approach to the TL junction. I can't think of a more powerful way of correcting non-fixed deformities with either a lateral or an expanded lateral technique like an ACR or a corpectomy. So contents, three ways of getting there. I'm going to do this mainly through case examples rather than just didactic slides. So just a brief teaser of kind of the anatomy. So when we talk about these three approaches, retroperitoneal, retrodiaphragmatic, retropleural, it really all kind of relates to the level of the thoracic and thoracolumbar junction you're trying to get to. As a generality, usually you can stay completely within the retroperitoneum. If you are working in between T12 and L2, some people, their diaphragm's more curved, and this may, there may be exceptions, but I think this is applicable to about 80% of the population. When you're working a little bit higher than that, between T11 and L1, oftentimes you have to mess around with the diaphragm and do retrodiaphragmatic. And then certainly in general, when I'm above the T12 disc space or T12 vertebral body, anywhere from T10 to T12, you generally have to enter the thoracic cavity itself. So this is kind of a beginning, kind of simplified schematic of it all. If you actually look at the anatomy, so that slide that I just pulled up here, this is a cadaveric dissection where we've basically shined a light into the thoracic cavity on the patient's left side. And you can see the thoracic cavity is illuminated, and you see this sharp demarcated border, which is the diaphragm. And I think what makes this kind of area confusing is that we're so used to using surface anatomy, but you can't really generalize where you are based purely off of the ribs. So, here's a T11 rib, here's a T12 rib. In between T11 and T12, there's a portion where you can be completely in the retroperitoneum, and there's a portion where you can be completely within the thoracic cavity. Similarly, above T11, if you go a little bit more ventral or anterior, you can be in another situation where you have access to both corridors. So, the surface anatomy doesn't really dictate which plane or cavity you're in. And if you go one step below that, you can actually see, here's a diaphragm cross section. Here's the, retroperitoneal with the retroperitoneal fat. And then, you see a little bit of parietal pleura here. And then here's the psoas muscle that we all encounter commonly with degen cases. Retroperitoneal approach, you're going to be sticking down here. Retrodiaphragmatic approach, you're going to be kind of aiming in this corner. And because of how curvy the diaphragm is, you can detach some of its connections and push the diaphragm up. And then similarly, for the retropleural transthoracic approaches, you're in the thoracic cavity, you'll move lung out of the way and you'll get to the side of the spine. So, here's a good example of just kind of a standard retroperitoneal approach here. So this was a patient I took care of, I think almost 2 years ago. 69-year-old, had this posterior lateral fusion between L2 and S1. You can see that she's developed adjacent segment, degeneration and pretty profound sagittal malalignment, thoracic hypolordosis, unable to walk, using a power wheelchair, and her spinal pelvic parameters up here. If we look at where the focal kyphosis is, it's really above her previous fusion. So here's L1, L2. You can see this, complete collapse of the disc space. The anterior vertebral bodies are touching. When we're talking about doing a sagittal reconstruction, this is going to give you the biggest bang for your buck, because this is really where most of the deformity is. This was the initiator, and I see this as maladaptive compensation. So my plan was to do a lateral anterior column release at the L1-2 disc space. If you look on the coronals, the L1-2 disc space is at the level of really the, if you're going far lateral, it's really at the level of the T10, T11 ribs. But really, we know that this space is completely within the retroperitoneum. Okay, just again, generalities. If you're below L1, you're pretty much always in the retroperitoneum. So my thought was we can get this through just a standard retroperitoneal approach. Let's see if I can hide this window here so you guys can see the photos here. And again, here's a coronal CT scan. Here's L2 down here. Here's L1, T12, T11. And you can see this patient has a very, very generous diaphragm. The diaphragmatic attachment really isn't until you're at really the T10, T11 level. So everything below here is all within the retroperitoneum. So we know that we can stay within it to get to this level. So, my plan was to do a lateral interbody fusion with an ACR, really pop open that kyphotic segment. And then we do a T2 to pelvis and then an L4 PSO to correct the original hypolordosis caused by index surgery. Here is an intraoperative film. Once we've gone down with the retractor, we're all within the retroperitoneum. We put a lateral interbody cage in there, and then we expand it. We pop the ALL. You can see just the amount of powerful distraction. And here's the end of the first stage. You can see that this area is almost completely neutralized. We still need to reconstruct this a little bit more, and also get some more lordosis down below, but we're able to safely get to that area just within the retroperitoneum without any issues. And the approach for this is just like any standard lateral lumbar interbody fusion. The ribs may be in the way, but if you go beneath the ribs, especially T11 and T12, you can just move those ribs out of the way and stay within the retroperitoneum specifically. Sorry, give me 1 sec. Someone's calling. All right. So at 6 months post-op, you can see the patient's doing very, very well. The PSO down here, here's the ACR. You can see the restoration of alignment is very nice. Extremely powerful technique, targeting the TL junction right there. And post-op CT. Okay. So another example. Now we're going to be working a little bit higher up. So, the zone where I think we can access the thoracolumbar junction with the retrodiaphragmatic approach is really T11 to L1. And this was a very notable example. This patient I took care of about, I think, a year ago. Memorable for many reasons. So she's 47 years old, had a previous T12 to L5 fusion, developed a horrible adjacent segment collapse. Another provider tried to do a MIS TLIF, but didn't really connect the rods. So there's like a standalone TLIF and then another TLIF above that. Needless to say, this did not end up very well at all. Couldn't stand, couldn't walk. Here you can see the CT scan, just looks terrible. The back wound was opened up. She somehow had a pain pump placed, even though there was this horrible deformity, the world that we live in. Her measurements, you can see, are grossly abnormal. Her SV is over 20. Despite all of this, her lumbar lordosis was actually pretty good. So she actually had a pretty well-matched lumbar lordosis to PI. It's really this area above that really broke apart and fell apart between T11 and T12. So, my plan, it's going to be a long segment reconstructed, T2 to pelvis. I thought that we would start posterior, just because if you look at the x-rays, one of the TLIF cages, shot out. Thank God this was in Camden's triangle and not, in the middle of the spinal canal. So my thought process was we're going to go in, decompress posteriorly first, get the cages out, and just see what the alignment does. Uh, on the preoperative MRI, you can see that there's this big fluid level, which correlates to right here between T11 and T12. Generally, when I see that, I mean, this is kind of like what you see in Encke spondy fractures. You know that this area is going to be unstable, and that when you position this patient prone, it's probably going to fish mouth open. So my thought process was we were going to do this posterior first. If we're able to reduce her alignment with a fish mouth, just lock it in place with rods, and then come in for stage 2 and just fill the gap with the ACR cage. And if we're not able to fully reduce it, just decompress and then come in from the side to reduce that kyphonic deformity, and then go back from the back to lock her down. So uh, we went posterior first, and just by positioning the patient prone, you can see how wide of a fish mouth gap there was. So we had already put in our final rod, and this patient's alignment looks pretty great. But the two halves of the spine here and here are really fully disconnected right now. There's maybe like a 2 millimeter segment of end plate touching each other. And then you have this big, 30, 40 degree gap that is just asking for biomechanical stress and breakdown. So we went in through a retrodiaphragmatic approach. And if you look at the CT scan after stage 1 or before stage 1, here's the area that we're targeting. So it's still below the line of the diaphragm. So here's the diaphragm right here. This is still within the retroperitoneum, but it's getting close to where the diaphragm actually is. So we know that we can probably stay in the retroperitoneum to get to this, but we're probably going to have to finagle with the diaphragm a little bit. But we were actually able to do that. And we were able to get a very, very generous, hyperlordotic cage in there, fill in the gap. Patient did great, went home. And then here's her 6-month follow-up x-rays. Looks great. I mean, she's doing very, very well. And then, the last example is, working through a retropleural approach. And this is where you're working higher up in the thoracic spine from T10 to T2, T12. This is a 29-year-old woman. I took care of her about 6 months ago. She was, I think, building a treehouse or something like that. There's some memorable story related to that, but she was building a treehouse and fell, began to have intractable back pain. And here you see this T12 burst fracture. When I showed this case to kind of several peers elsewhere, I got a very, very kind of split response from people. A lot of people said, you know what, this is a very mild compression fracture. It's a superior end plate deformity, which I completely agree with. But even though I think this is kind of a mild fracture, and yes, if you look at this scoliosis X-ray, and this quote unquote doesn't look that bad, I think for us, the typical patient population that we see are people in their 40s, 50s, 60s, and above. This is a 29-year-old woman. I disagree. I think that this X-ray is really not very good for a 29-year-old. There was pretty significant focal kyphosis and an increase to about 30 degrees. You can see that when she stands up. So in my view, this is an area where I want to get her alignment as close to normal as possible, just for longevity. So now we're working in in the thoracolumbar junction above T11 or above T12. Very small vertebrae. If you look at where the fractured vertebrae is, T12, unlike the last example where, this was in the retroperitoneum, in this patient, you can clearly see that this is pretty much inside of the thoracic cavity itself. We're already kind of above the crus, the insertion of the diaphragm at this point. So I knew that if we were going to go in and fix this, we actually have to be in the thoracic cavity itself. So we do the approach by removing a little rib, we move the lung out of the way, and then we are in the thoracic cavity, but we're still in the TL junction. And my plan to do this was to actually do an ACR. I mean, she had about 19 degrees of focal kyphosis. The only way you're going to get more than 10 degrees with a lateral is if you release the anterior longitudinal ligament. So we did an ACR, and then we did perc screws, lock it down. Here's the kind of typical ACR workflow. This low anterior blade, scalpel, we cut it, cob it, and then trials to pop open the space, bigger trials, even bigger trials, and then box cutter. And then finally, because she's so small, we have to use a pituitary as a temporary disk space distractor, but we're able to get a ACR cage in there. You can see that this area is now almost completely parallel with the perk screws. And 3 months later, before and after. So, when I saw the post-op X-rays, I really thought, okay, I'm positive we made the right decision. If you even just look at her SVA, it's right over the posterior portion of her sacrum. Very, very good result, and she's been doing great. So, in summary, this is a topic that I think oftentimes can be very, very confusing and very challenging for people to kind of explore in terms of this area and with this anatomy. But the way that I simplify it again is that there's really kind of three ways of getting there. You either stay in the retroperitoneal cavity, you either do it traditionally by moving a rib away, or you mobilize the diaphragm. And if the diaphragm is already below the disc face on the coronal CT, then you have to go into the thoracic cavity and get this thing taken out through a retropleural approach. And that's what I have right now. Questions, comments about the topic, about any of the cases I presented, anything along those lines?
No, phenomenal talk. You're a lateral expert. I mean, I'm always super impressed with what you can do from a lateral approach. It's a super powerful approach. What advice do you have for people that maybe are just starting on the lateral space for exposure? Is this something that early on, getting thoracic to help with, getting vascular surgery to help with the retroperitoneal? What advice do you have for people that are just maybe like entertaining, starting to do lateral approaches?
Yeah, so that's a great question. So the learning curve for this is still a work in progress for those of us that do it. I would say that when you start off doing laterals, the kind of gradation that most people that we generally recommend is that you do laterals targeting kind of the sweet spot areas first that are, quote unquote, low risk, kind of easy, straightforward anatomy, L2-3, L3-4. After that, then you move on to L4-5 for your retroperitoneal, standard retroperitoneal approaches. After L4-5, then you start kind of advancing cranially because you get a better sense of how you position and move the retractor. You can be more comfortable moving the ribs out of the way. And then from then on, most people will start working towards trying to do a lateral corpectomy by getting a bigger exposure, working around the other structures. And then finally going in the chest, if you're going to do, lateral thoracic corpectomy or lateral thoracic, discectomy for a thoracic disc. In terms of getting through the exposure, my honest recommendation is that you contact industry and you go to a lab. And several of the industry partners that really design the platforms for laterals, like NuVasive Globus, Alphatech, Medtronic, they have invested a lot into surgeon education, and they'll get basically a proctor to sit with you and actually do this in a cadaver. They'll help you review films for your first case, kind of simulate and go through it. I think it's actually a disservice sometimes getting a separate approach surgeon to try to work through this approach because almost every single time in the past I've had thoracic surgery assist. You tell them, okay, I need to get to the thoracolumbar junction. I want to do it through a reasonably sized incision, like 3 or 4 inches. They have no idea because what's important to us in terms of getting to the spine is something that just never occurs to them in what they do. Like you tell them, okay, I need to see the side of the spine. Are we going to preserve the diaphragm? The most common answer I get from most thoracic surgeons is, oh, whatever. You can either just, blow through the diaphragm and sew it up, when you come out, or just do a massive, massive thoracotomy, move a bunch of stuff out of the way, which I think is super morbid and kind of defeats the whole purpose of doing this approach. So I would advocate that, the best way to learn this is to really rely on the resources that the industry already has. And there's some very, 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 not just generic courses, but, one-on-one proctorship, pathways that are in existence that can help people out.
Awesome. Great advice. Any other questions about anything? Very good. Well, thank you so much, Dr. Shu. It was a fantastic talk. I always enjoy hearing you speak about lateral approaches. And yeah, everyone have a good evening.
Yep. Have a good night, everybody. Thanks for having me on.
All right.